This is Dr. Scott Geller. I am in private practice in Fort Myers, Florida. This is my presentation to the Florida Society of Ophthalmology meeting in June 2018. We're presenting this right now in this form because the actual event was shortened due to some time constraints. And I think it's important for our colleagues to understand a little bit more about this niche area of ophthalmology that has gotten a lot more publicity with the advent of the LX laser company that is currently promoting its machine, but there have been no courses or real in detailed presentation by experienced ophthalmologists. This is our usual disclaimer. I don't have any financial interests or product interest from any manufacturer in this area. Well, here's something all ophthalmologists should know. It's good advice. Knowing what to do is not the problem. Knowing what not to do is. I'm speaking with 30 years of experience. I studied under Professor Franz Funkhouser in Bern, Switzerland in the 1980s. Professor Funkhouser was the main innovator of the YAG laser for ophthalmic use. And his initial idea was to use it to cut diabetic membranes within the eye without using a vitrector. Professor Funkhouser did all the basic research. It's all there for anyone who wants to find it. However, the good professor never really thought of treating eye floaters with it. He thought it was sort of frivolous. Well, since that time in the mid-'80s, I have done more than 20,000 vitreous laser sessions. I can easily say that I'm probably the most experienced ophthalmologist, perhaps worldwide, in this area. I gave my first presentation in 1989 at the International Congress of Ophthalmology in Singapore. That was followed by a presentation at the European Congress of Ophthalmology in Prague, at the European Congress of Ophthalmology in Istanbul in 2001, and actually at the Florida Society of Ophthalmology in 2002. In 2010, we gave a presentation at the ASCRS meeting in Boston of unnecessary capsulotomies due to a misdiagnosis of floaters. I also presented that at the International Congress of Ophthalmology in Berlin and gave a presentation to the ophthalmologists in Nantes, France. In 2012, we presented at the Orione Congress in Italy. And in 2012, we had a poster presentation at the American Academy of Ophthalmology on the complications of YAG laser vitreolysis. In 2013, I again presented in Italy and was invited back in 2014, at which time not only was there a presentation, but I gave a mini course and performed laser on several patients there. 2015 again, we were invited back, gave a presentation to the Italian Ophthalmological Society, and in 2016 at the World Congress of Ophthalmology in Guadalajara, where I presented on YAG laser vitreolysis of vitreous membranes, which is another little subheading I'll go into in this talk. In 2017, I was invited to my alma mater, Rush Medical School, to give a presentation before their ophthalmologists. And in 2018, we gave a didactic course before the American Osteopathic College of Ophthalmology, which was in Bonita Springs, Florida. Well, the questions ophthalmologists always ask, does it work? Well, the answer, of course, is yes. Does it always work? No. And the key to doing this is knowing what works and what doesn't work. Of course, our goal should be the best outcome given the limitation of current technology. The technology is not progressing that fast in this area, but if we choose the patients right and know what we can and cannot do, we'll get a good result. So let's give you a little historical overview. In 1985, Professor Funkhouser had a paper where he stated that YAG laser vitreolysis should receive some increasing attention. There's a QR code that will be included with this presentation. You can scan the code, and there is a complete bibliography you can download if you choose to research the literature, which is actually quite extensive, but a lot of it is not online because in the 80s, when all the initial research and animal studies were done, those things haven't been brought forward for internet access. Everything I'm going to say is anecdotal, but let's review some of the scientific stuff. Funkhouser did all the YAG research in the 1970s through the 1980s. And that's the basis for my proceeding with doing this. All the basic research was done. I hear from other ophthalmologists, well, there isn't enough research, we don't know what it can do to the retina, et cetera, et cetera, et cetera. Well, actually, the fact is, it is out there if you choose to pursue it and research it. All the information is there. Summing up the early papers, we know that the YAG laser can be safely used 3 to 4 millimeters from the retina. So why exactly is there this negative spin out there? Well, if you go back to the early literature, when YAG lasers first became commercially available, there were some reports by some well-respected academics that reported failure with laser vitreolysis for eye floaters. And they also reported complications of elevated pressure, retinal damage, et cetera, et cetera, et cetera. And this, in my opinion, sort of poisoned the well. And, you know, in the academic centers where residents are trained, the residents can go to their chief and say, hey, I'd like to try this. And the chief will say, well, you know, it was reported in the 1980s that this and this and this can occur. So it's a failed procedure, it's bad, and I'm not going to let you do it. And by the way, I tried it back then and it doesn't work. So it was poisoning the well, not a good thing. Well, currently there are some clinical papers out there now. Here's another one that's a negative one in January 2015, American Journal of Ophthalmology, refractory glaucoma after YAG laser vitreolysis. There have also been some reports of cataract after laser vitreolysis. There have been a lot of reports in the, what I call the secondary European literature, you know, the Polish Society of Ophthalmology, the Austrian Society of Ophthalmology, the Bulgarian Society of Ophthalmology. With the advent of the LX unit and the commercial promotion of YAG vitreolysis, a lot of ophthalmologists are jumping into it without any training whatsoever, and that's what happens. Complications arise. The unfortunate patient will be running around to other ophthalmologists in his location, and those other ophthalmologists, of course, will latch onto this and write a paper on complications they have observed. In September 2017, JAMA published a paper by Shah and his group of YAG laser vitreolysis versus a sham YAG laser for eye floaters. Also in September of 2017, Han and the American Society of Retina Specialists, a small committee of interested ophthalmologists, retina specialists, wrote an editorial on complications following YAG laser vitreolysis. Well, of course they would. It is terrible to see complications. The doctors who performed this procedure without any training had these unfortunate complications. And of course, they've gone up the ladder to other specialists who I'm sure were appalled at these problems. Well, Shah's paper was very interesting, and I would urge you all to read it. There's a QR code that you can click on to download the actual paper. But there's several interesting things about this paper that I can go over with you. And if you read it, Dr. Shah stated laser treatment ceased after vaporization of Weiss rings and all other significant floaters. Actually, if you look at the title of the paper, it's laser treatment of Weiss rings. So what are these other visually significant floaters? So he actually wasn't treating just Weiss rings. The other thing that I think is totally erroneous is this use of the word vaporization. Those of us who do this procedure know that nothing at all is vaporized. It is pulverized. Pulverization is completely different than vaporization. If we had vaporization, when you did a capsulotomy, you would notice that the capsule turns into a vapor. Of course, it does not. Everybody knows that. The other interesting finding on this paper was that 31% of the sham group reported improvement. Well, that's interesting. A sham laser where nothing was done to the eye, a patient reports improvement. How is that possible? Well, I think there's two answers. One is that the patients were invited to be a part of a study. I'm sure they were told that they were trying to assess the validity of a new treatment, and the natural inclination of a patient would be to please the doctor. The doctor is trying to do something positive, and the patient says, yeah, it seems better to me. The other thing that I think influences the patient's opinion is that they didn't have to pay for this. There was no insurance, the copays, the patient wasn't charged at all. And the natural inclination would be to please the doctor again. And I'm wondering if the patient were actually charged $2,000 for this procedure, whether they would have actually said that, yeah, my $2,000 was well spent, it worked. I'm not sure that would have happened. 8 of 36 patients that Dr. Shah did the actual procedure on reported no improvement. Now, I find that very, very suspect if the patient or the doctor was actually going after a Weiss ring type of opacity. No improvement? Well, I have an answer for that. I think that when the patient was invited, because Dr. Shah noted a PVD and thought this would be a good subject, the Weiss ring wasn't actually what the patient was complaining about. It was something else. And that goes totally with taking a proper history and knowing what you're doing. Now, the other interesting thing about that paper was Dr. Shah objectively reported 100% of the so-called Weiss ring type of opacities were gone, yet the patient reported no improvement. And that goes back to poor history taking of exactly what was going on in the patient's eye. Also interesting, Dr. Shah reported that there was no learning curve. Well, that's interesting. How can there be no learning curve with this if the patients reported no improvement? So although Dr. Shah advanced science with this interesting paper, I think it was not set up too well on a very scientific level. So let's go into this video here. Why would there be no improvement? Well, I think it's poor history taking. And patients, are not always as articulate as we would like them to be. They can, well, I've got this eye floater. I know it's a floater. It's something that comes across my field of vision. And an untrained ophthalmologist will look in, he'll see a simple Weiss ring, a Highland type of opacity as we see in this video, but that might not be what's really bothering the patient. It's all about the history. What is this like? What are you noticing? Is it very distinct? Can you describe a shape? If it's very distinct, of course, it's close to the retina, but if they say, well, it's like this big Vaseline mirror that goes across my field of vision, it's not the Weiss ring at all. It's something else. And that's where some good training and education come in. If we go over that issue of the JAMA issue of September 2017, Dr. Lim gave a commentary on this. She also repeated this misinformation that floaters are vaporized. She stated that the paper was directed at single Weiss rings when in fact the paper actually stated it was Weiss rings and other significant opacities. And she also made the statement that complications were unknown, which is not true, and I'll get into that later. The Han commentary of the complications following laser vitreolysis, I considered that a hit piece, putting out a very negative spin. And the Cowan paper of glaucoma, that was UCLA in California, reported that glaucoma was a late onset complication. They saw the patients perhaps 8 or 12 months after the initial procedure and made the assumption that nothing transpired for 6 months. I can tell you from my personal experience, this is absolutely untrue. It is not a late complication, and if you look at the paper, you will see how it is flawed. In 2012, we gave a poster presentation at the American Academy of Ophthalmology. It was in the retina section. I call it in Siberia, the last row of the retina section. It received interest for those who ventured into Siberia, but it was quite an extensive group of patients. We had 542 eyes of 502 patients. I was the surgeon one with 25 years of experience and had 3 eyes with elevated intraocular pressure. One patient required a cyclodialysis surgery to reduce intraocular pressure. My other colleagues, surgeon number 2, had observed complications of a lens opacity, and my third colleague from Amsterdam, who had 302 laser sessions of 143 patients, reported elevated intraocular pressure in 3 eyes, retinal hemorrhage in 2 eyes, and a retinal tear in 1 eye. I would like to comment on that about retinal tears. I did observe one maybe 15 or 20 years ago after I had done a single laser session on a high myope. But my own opinion of that was that I probably missed it in the initial evaluation. Nowadays, I'm very, very careful to evaluate the peripheral retina with a Goldman contact glass to see if there are any occult retinal tears. They can be found in a very small percentage of patients. When I see them, I will laser them, argon them, just for safety's sake. This is an interesting slide. Most ophthalmologists have never actually seen the inside of a laser. This is the Lazog Microruptor 2 laser category. I consider this the world's best laser for vitreolysis for various reasons. The actual laser rod is about the size of a ballpoint pen. It is placed in they call it the laser cavity. It is a gold-plated parabolic mirror with a xenon flash lamp that excites the rod. YAG yttrium aluminum garnet crystal doped with neodymium atoms. Let's go into contact glasses. This is really, really, really important for anyone considering YAG laser vitreolysis. Contact glasses are the key to doing this safely. If you don't understand how they work and why they're necessary, you're going to have problems. The actual optical breakdown phenomenon occurs in an elliptical shape, and the phenomenon starts distal and proceeds towards the operator. This is an interesting slide. This is an opacity in the posterior capsule of the lens of a phakic patient. This was a complication of a prominent retinal specialist in Florida who just jumped into it. And like many ophthalmologists, they think they know everything, but they don't. The very interesting part about this particular patient, he was about 50 years old. He came to me after he got a little jumpy because his ophthalmologist did not get the opacity. And he had the feeling something had gone wrong. He was blind, or I should say he had a central macular lesion in his opposite eye with probably, I believe, 2400 vision from ocular histoplasmosis in the operated eye. So he was basically a one-eyed patient. The operated eye had some histo spots, but his acuity was 20/20, best corrected. When I saw him, I was a little surprised. This was probably about a month after his laser session. This was 2 or 3 years ago before this presentation in 2018. I gave him a call on the telephone before this presentation to see how he fared. And surprisingly, the lens opacity had not progressed. It had just self-sealed. And any ophthalmologist who's seen eye trauma can verify that once in a while you'll find a patient who got a pin or a nail in his eye that hit the lens of the eye, and it self-sealed without the progression of visually disabling cataract. So he did okay. I just told him if he ever did develop a cataract, have the ophthalmologist who was going to do any surgery, please give me a call, because with that weak capsule rupture, it would be a complicated surgery, especially in a one-eyed patient. By the way, most ophthalmologists have never seen a slide like this. This is the anatomy of the vitreous. This is from a stereoscopic book given to me by Professor Jan Worst from Netherlands. Professor Worst passed away at this point, but he performed a great service. They did a dissection of the vitreous under some hydrocarbon solution. They injected the vitreous with various opaque solutions to delineate these various areas and cisterns that you can actually see. Anybody interested in laser vitreolysis probably should get a copy of the book or go to an ophthalmic library to view it. There are some stereoscopic viewers with the book and see what it looks like in 3D. So let's go into the evaluation of the symptomatic patient. Like I said before, patient history is the most critical part of this examination. Many patients are not observant or articulate enough to say anything more than my vision is blurred. And I have seen this at least dozens of times that patients have come to me. They've had unnecessary cataract surgery and unnecessary capsulotomies because you know how it is out there. Patient goes in, they go into their ophthalmologist who performed cataract surgery. They might be evaluated by a technician or an OD on staff. They're not articulate. They say, you know, my vision is blurred, it's been going on, and they're not articulate enough to say, well, it's an intermittent phenomenon, I shift my head this way, and it gets clear. The assistant looks at the eye, sees some minimal capsule haze, said, oh, this will do it for you, and they have their capsulotomy, and the patient wonders, well, how come it's not better? So they actually get sent around the medical mill. They're sent to a retinal specialist who does their fluorescein angiograms and whatever else they do and finds out the fluorescein is negative. Sometimes they really don't listen to the patient either. They look on the chart, the patient's 20/20, and they think, well, this is another crackpot that says his vision is blurred. Let's send you to the neuro-ophthalmologist. Well, the neuro-ophthalmologist does his thing, runs a zillion tests, and comes up with nothing. And then the patient will go to the local optometrist in eyeglass world. Their local optometrist will look at it and say, you know, you got this big ball of fuzz behind your implant. The patient will say, what do you mean? Well, you've got this giant floater there. Here, why don't you move your head a little bit and see if it clears? He says, yeah, it does. Oh, well, you've got an eye floater. And then they come to me, and that's where they're treated. We gave a paper on that, at the ASCRS meeting in 2010, as I mentioned before. That was in Boston. And that same year, I presented the paper at the European Congress of Ophthalmology in Berlin. And it got a little interest. Oh, that's interesting. Well, I don't know if I'll use that in my practice, but I'm going to do the capsulotomy anyway. My standard protocol when I evaluate a patient is to measure their worst visual acuity. And I've stated this in meetings many times. Ophthalmologists are confused because they have the patient evaluated by their staff. The patient's natural inclination is to get the best visual acuity that the doctor wants to see on the eye chart. They move their head around, they see 20/20. The staff doesn't really understand what the patient is doing. They write down 20/20 in the eye chart. The ophthalmologist comes in, looks at the chart, the patient's complaining, and of course the patient is relegated to the nutcase category. So you got to ask the right questions. What do you mean your vision is blurred? How is it blurred? I see 20/20 on the chart. You mean to tell me that if you move your head, it gets better? Yeah, that's what happens. Or a patient will say, well, I blink my eyes, and actually what they're doing is moving their eyeball. I blink my eyes and this clears up, and that leads to another misdiagnosis. The misdiagnosis, or I should say misdiagnosis, not missed. The misdiagnosis is dry eye syndrome. You know, there's a lot out there in the ophthalmic tabloids. Oh, the retina or the cornea surface is where it's at, and if you don't get that right, the patient's going to have blurred vision. And to somebody who's not really tuned into listening to what the patient says or understanding what can happen, I've seen this many times. Well, they said I had dry eyes and gave me these drops and my vision is still blurred. They just don't get it. The other thing that you have to understand if you're ever going to evaluate floater patients is the phenomenon of visual snow. I've seen patients with visual snow. They are younger. They're usually in the age of, I'd say, late teens to mid and upper 30s. And it is a very, very unusual neurological phenomenon. It finally got a little bit of airplay in the journal Brain. It was a very well done paper with participants from the United States and from London. And it went into the details of what patients describe. And if you're going to do eye floaters, you should click on the QR code that I have here and read the paper. I also have a QR code that you can use to see some actual patient descriptions of patients that have come to me complaining of eye floaters. They've been to other doctors that have said, oh, you must have floaters. You see these things. Well, guess what? They don't have floaters. They have visual snow. And I've seen this from very prominent retinal specialists. I think they're just very busy. They really don't want to hear it from the patient. They put the patient into the nutcase category and say, well, we can't do anything about it, go away. Let's go into the typical descriptions of opacities in different vitreous locations. This is really important to getting the optimal result if you're going to do laser. You can lead a patient with questions and also use this terminology, but this is a classic description. The patient will say, this is like a windshield wiper. What do you mean? Well, I'll be driving along, my vision will be clear. I'll look into the side view mirror, come back to the center line, and all of a sudden this windshield wiper goes across my field of vision. Or they'll say, I look down to read, and all of a sudden things get blurry, and then it'll clear up slowly. Or they'll say, it's like looking through grease. Well, those types of floaters are usually very anterior. They're usually fibular degenerative masses. Those that have actually looked closely at the vitreous will know what I'm talking about. They look like a big cotton candy ball or a little ropey Christmas tree decoration. They'll usually float right behind the natural crystalline lens or behind an implant. Very often, this will be the complaint of a patient who's had a PVD, post-cataract surgery, which, by the way, is much more common than most cataract ophthalmologists would like to admit. Patients sometimes say, well, it's a very distinct shape. What do you mean distinct? Well, it looks like a sperm cell. I had one patient say it looks like a Klingon warship. Just today I had a patient say, well, it looks like a seahorse. You know, I can see the little tail, it's curled. Those types of floaters are usually very close to retina. If you question them further, well, where is it? Is it about the horizontal midline? Yeah, sort of like that. Is it more or less maybe 20 degrees lateral? Yeah, and I turn my head and it comes in and then it goes back and it looks just like a seahorse, or it looks like the planet Mars or some constellation if it's a, not quite a Weiss ring, but just a Highland opacity. And that's very important to understand what the patient is complaining about. When a patient comes in and says a center spot, even in a darkened room, that's a very big clue. That usually means that it's in the central visual axis, of course, and very, very close to retina. They don't need a small pupil to get a defined shape or see the blur. It's just there. Sometimes they'll say they can see it through closed eyes with just ambient light. This is an interesting video here. There it goes, right there, that little opacity. There is an anatomical place in the vitreous called the premacula bursa. I have never been able to see one of these things with an indirect ophthalmoscope. I've never been able to see one of these with a direct ophthalmoscope. This video is through a Goldman lens. These things are very, very difficult to find. You have to persist and find them. But if they say, I see this thing, it's always in the central 20 degrees and it drives me crazy, it's in the premacula bursa. I have found these things to be untreatable by laser, and the patients are extremely frustrated. Sometimes they go on to vitrectomy. I think the oldest patient I've ever seen with this was about 40 years old. It was a gentleman who actually came all the way from Russia to have it treated. I just had to give him the bad news that I thought this was not treatable with current technology. You know, vitrectomy was an option, but he did not want to go through with that. The interesting thing, by the way, about this is that usually these patients have gone to other ophthalmologists, retina people, optometrists, and the answer routinely is, yeah, I see the floater. I don't believe they ever saw the floater. I think maybe they saw something in the vitreous. The vitreous is never totally transparent. There's always something to see, and it's very easy for an ophthalmologist to not appear that he doesn't know what he's looking at and say, yeah, sure, I see it. It's in the mid-vitreous. And they called me up on the phone. They said, well, my ophthalmologist said it was in the mid-vitreous. Can you get it with laser? Yeah, sure, come on, let me examine you. And they come down, and I examine them thoroughly, and it's in that location, and I have to give them the bad news that at this time, I can't help them. So anybody who's really interested in treating eye floaters should understand that. In my experience, I find indirect ophthalmoscopy very marginally useful. I think the slit lamp is essential for detailed examination of the anterior vitreous body. My personal preference is for a Hochstreit slit lamp with convergent optics versus the Zeiss with parallel optics. It can be done with both, but I find the Hochstreit much better. I don't like any of the cheap copies of the Hochstreit, but that's just my personal preference. I do think the optics are superior. And if you're going to treat, you better have the best equipment you can get. In my practice, a Goldman-style contact glass is absolutely essential to examine the vitreous gel. If you're not comfortable with examining with a Goldman lens, you better start using it to really understand what's going in there and actually visualize what the patient is talking about. So let's go over the common misdiagnoses again. I think this is real important to reiterate. I think the misdiagnoses are always due to failure to elicit an adequate history and sort of think outside the box. What's the patient talking about? I actually had a patient this week that I'm dictating this presentation who came in with a complaint of really blurred vision. The guy was a retired 65-year-old electrical engineer, really fastidious guy, you could just tell. And he said his vision was really blurred. I looked in there and saw, just a few little fibular fibers, nothing like he was describing. And I actually went a little further, did an OCT of his fovea, did a visual field, just to make sure I wasn't missing anything neurological or retinal. It turned out that it was these small fibers, and patients have different descriptions of these things. Dry eye syndrome, as I said before, is a common misdiagnosis because there's so much fluff about dry eyes and how it's so important after cataract surgery to get the ocular surface. I think a lot of that is hype, personally. But because the patient says, well, I blink my eyes and it gets better, here, use these eye drops and you'll be okay. But they never are. A cloudy capsule, we talked about that before. Patients just are not articulate enough to say it's an intermittent blur, not a constant thing. And even cataract, a patient will say, my vision's really blurred. I drive down the road. They go into an office, I call it cataract hustlers, you might say. They're put in front of a so-called glare tester, and it's like, oh, this is what you have. We're going to take this cataract out, and you're going to see perfectly. Well, they do see 20/20 after a nice procedure, but it doesn't take care of their problem, and they're wondering, why did I have this surgery when I still have this issue? The other thing is, with all these misdiagnoses, they get unnecessary referrals to neuro-ophthalmologists and retinal consultants. Ultimately, somebody tells them they just have a simple eye floater. One of the most important things for anybody to understand getting into this procedure is to give the patient realistic expectations and really an informed consent. There's nothing like an unhappy patient to ruin your reputation. And if the patient understands exactly what can be done, everybody's better off. So patient satisfaction depends on several identifiable factors. One is the density, size, location of the opacity, and the training, skill, and experience of the operator. And most importantly, the specific model of the laser and the method used. I'll go into the models of laser. I personally think that the Lazog laser Microruptor 2 is absolutely the very best for technical and depth of field reasons. I've used the LX laser. It works, but it does have some deficiencies, and I have not bought one of those. Not to say that it doesn't work. Other doctors, my colleague John Karakoff, whose floaters I did up in Virginia, has been using it for a decade and seems to have good results, but it can't get everything. Let's go back to the informed consent. There is a learning curve with this, no matter what they say in their academic papers. Complications are uncommon, but you will see them. And I think a full and honest disclosure is the best protection from any kind of malpractice suit. And you have to educate the patients if their expectations are unrealistic. Sometimes they've heard from either something online or something they read that the floater can be vaporized. They call it floater removal surgery, which is not really what it is. And they expect to come out with the vision they had before the onset of the floater, or even when they were 25 years old, which we know is not possible. So be honest with the patient, and you'll have a happy patient. Let's go into the laser treatment parameters. This is how I do it, and giving this advice based on my own experiences of thousands of patients. In a simple hyaline, Weiss or ring, or as we say, a sperm cell or a Klingon warship, it's best to use a high burst mode if your laser is capable. The Lazog is capable of a burst mode of up to 9. I know the LX laser is capable of a burst mode up to 3. I personally use about 8 pulses per shot. Low power is essential in treating these things. I use about 2.5 to 3.5 millijoules and vary that based on my observation of the optical breakdown phenomenon. The breakdown phenomenon can vary due to the natural crystalline lens, any prior LASIK or radial keratotomy that will degrade the beam. It's something you learn with experience. The reason for using low power and a high burst mode is to avoid displacing the opacity in an area posterior to the hyaloid. If you use high power and literally blow out the hyaline opacity behind the hyaloid, it becomes much closer to the retina. It's harder to get, and sometimes it can really hide peripherally. You have to go back and get it. Retrolenticular opacities, these are often associated with PVD and with hyaline opacities, as well as John Karakoff initially described as a floater duet. These retrolenticular opacities are classically described as a windshield wiper or a grease spot that moves across the field of vision. And they can actually be quite disturbing, especially to one-eyed patients, because even a fairly small fibular mass with a small pupil can obscure the visual axis totally. In these cases, if it's a phakic patient, use very low power, a half to 1.5 millijoules, and maybe 1.3 pulses per burst. Retrolenticular opacities, these are often associated with a PVD and sometimes with hyaline opacities that Dr. John Karakoff initially described as a floater duet. Classically, a patient will describe it as a windshield wiper or a grease spot that moves across their field of vision. And these can be very, very disturbing to one-eyed patients because they take up a lot of the visual axis of the pupil and can obscure the object that the patient is looking at, especially if they're driving or engaged in other type of activities. These can be treated. You have to be extremely careful, otherwise you will nick the lens of the eye. I always use very low power, a half to 1.5 millijoules and maybe 1 to 3 pulses per burst. Using more pulses puts you in a bit of a danger zone. You can assess the quality of the optical breakdown, and you have to be extremely, extremely careful. On these type of opacities, I've used the CGP contact glass, which is now marketed by Hog Strite. I have also used the CGA contact glass, which is shooting into a mirror. And although Goldman lenses are not recommended, mirrored Goldman lenses, for various reasons, I have used them to get to the floater. If you are really experienced and know what you're doing, it can be done. But at this point, for somebody without extensive experience, I would say avoid it like the plague. Very common are these mid-vitreous fibular masses and hyaline membranes. I usually limit sessions to 200 to 500 pulses and treat at 4 to 6 pulses per burst. You know, in these cases, multiple sessions are needed. When you get above the 500 pulses, you run into I'd say, a danger zone for complication of elevated intraocular pressure. Preretinal opacities. These are usually seen in younger patients. They are often not associated with any kind of PVD. It's usually early vitreous syneresis. You see this occasionally with LASIK patients, post-LASIK. Very difficult to treat. It can be done. I always use a low power, 3 to 4 millijoules, and a very low pulse rate to avoid any issues with the retina. So let me go over some observed complications. These are my direct observations. Fortunately, in my case, rare. There's a myth out there, and I call it a myth because I've said that I've done maybe 20,000 laser sessions over the years. There's a myth out there that retinal detachment is an issue. I don't believe it is. I have not directly observed a retinal detachment. I did talk to Kirk Packo. He's the chairman at Rush. Patient that I did that went to him, he did say he observed a retinal detachment. That was years ago. I called him back recently and wanted more details of that. How long after the laser session did it occur? Was it just a retinal tear with a delineated area of detachment, or was it a full buccal session? Unfortunately, he didn't have those details for me. I have no doubt that a retinal detachment could occur with an inexperienced operator or somebody who did not examine the retina very thoroughly before they attempted laser. But I can honestly say, in all these years, in all these cases, I have never observed one. And that's why I say it's important. Check for existing retinal tears and know how to seal them with laser. The last thing you want to do if you get into this is to examine a patient who comes to you, there's a retinal tear, and you're not timid to do laser in the vitreous, but you're too timid to seal a simple retinal tear with an argon, which is a see one, do one, teach one procedure. The most troubling potential complication is elevated intraocular pressure. You have to give special consideration to pseudophakics with an open capsule or vitreous prolapse. These cases can be done, but I always proceed very, very slowly with laser in these cases to see how the eye responds. Also, excessive laser in phakic patients with retrolenticular opacities. When I say excessive, I'm talking about more than 300 pulses in the retrolenticular area can cause elevated intraocular pressure. Any procedure with more than 600 pulses per session, that puts you in a bit of a gray area. It can be done with very low power if you're going after Y-swing type of opacities. But if you're using the normal power that I use, you run the risk of complication. You can also see elevated intraocular pressure with pigment dispersion syndrome. If there's any hint of a Krukenberg spindle or a Shea line on the natural crystalline lens or deep pigmentation of the trabecular meshwork, that is a gray area. You have to be very careful and moderate any kind of treatment. I've also noted that treated glaucoma or glaucoma suspects can be in that group that you have to proceed very gingerly with. One of the things I do to avoid complications is always take the pressure in both eyes. The opposite eye, the untreated eye, serves as a basis for the treated eye. If a patient comes in with a pressure of 15 in each eye, and we assume that intraocular pressure really doesn't change that much, a little bit of a diurnal curve, but 14 one day, 15 the other day, 16 the next day is not unusual in any kind of routine ophthalmology practice. But I have staff take the pressure in both eyes. That's so they serve as a check on themselves of what they're doing. If they get a pressure of 10 in the treated eye and the opposite eye was 15 initially, and we assume that it was accurate, we know that the 10 is probably wrong. They made a mistake. And I always spot check the staff. It's very important to spot check them. If they get an erroneous pressure and you proceed with additional laser, you can cause serious, serious problems because there's an additive effect with additional laser. I would also say that if you're not capable of doing glaucoma surgery, don't get into this. There's nothing worse than having to send your patient out to somebody else to do an operation, and your reputation will suffer because of this complication. By the way, one of my favorite operations for simple elevation of pressure after laser vitreolysis, which fortunately is rare in my case, is a cyclodialysis procedure. Very few ophthalmologists do cyclodialysis, but if you are capable of it, I would say give it a try. If you want to know how to do one, come and watch sometime. When you take a pressure after doing laser vitreolysis, if you have a pressure 5 to 7 above the baseline, the best is to hold off on additional laser. Sometimes a patient will come in from out of town and we do sequential laser on them up to 4 days. And if the pressure becomes elevated after one of those sessions, we stop and tell the patient, listen, this is where we're at with it. It's prudent to hold off, just come back and we'll deal with the floater. Even though we haven't gotten all of it, I'll extend the post-op period and wait for things to go down. The other thing about intraocular pressure is it can lag by 24 to 48 hours. So if you get a pressure, let's say 5 millimeters mercury one day after the procedure, it might go up to 8, 3 days after the procedure. So proceed with caution in these patients. Crystalline lens strike. Well, these are with those retrolenticular opacities or with an inexperienced ophthalmologist who doesn't have his aim correct. You can practice on patients, well, not really practice, but if you do have retrolenticular opacities, you can shoot in a pseudophakic patient with a regular capsule and maybe see how close you get before you get a capsular tear. That won't hurt the patient, but will help you understanding how the laser functions. Retinal thermal burns. Here's a picture of a thermal burn. These are basically not hemorrhages of the inner retinal layers, but usually it's a thermal burn of the choroid. These usually happen when you're doing excessive laser off axis. In other words, a peripheral opacity where you're not getting a very perfect focal point. You'll get the optical breakdown, but you'll get an optical breakdown that won't be really focused perfectly. And although you'll get the optical breakdown, there'll still be a lot of thermal energy that will go posterior. And of course, it's absorbed more by pigmented material like the choroid. And rather than just a little thermal whitening of the retina, you'll get a frank hemorrhage. That is a very scary phenomenon. When you see something like that, what you have to do is put firm pressure on the contact glass. Just tell the person that you're operating on that you have to put some firm pressure on there. That will stop the bleeding in most cases. And invariably, the little stream of blood that you will see streaming down the face of the retina will dissipate, and in virtually all cases, the patient will not notice anything. And like I said before, usually these are from those peripheral opacities that you did not have a proper focus, and you used a very high pulse rate, so the thermal energy to the choroid was beyond the threshold, and that's what will happen. They do heal up. I have not had one in a long time, but when you start treating floaters that are close to the retina, to really get a good result, this might happen. Thank you for listening. I'm Dr. Scott Geller, ophthalmologist, Fort Myers, Florida. You can reach me at my office, 239-275-8222. I'm more than happy to speak with colleagues about my experiences and how to avoid problems.